I'm Dr. Kaushalya from Sri Lanka. The topic of my case presentation is paradoxical postoperative hypercalcemia and acute pancreatitis following parathyroidectomy. Next 15 minutes will be covered the history investigation of my patient and the differential diagnosis and the diagnostic workup and the management and the take-home message and the references. So my patient is 50 years old, previously healthy male, presented with fever, chills and rigors, loin pain and dysuria symptoms for 2 weeks duration. His past medical, past surgical and the drug history were unremarkable. On examination, he was averagely built, febrile to touch, and the blood pressure and pulse rate were normal. And the abdominal examination was normal. And he was found to have left-sided renal angle tenderness. The basic serum and the urine investigations we have done. So he had normal serum potassium, serum sodium, serum potassium level with mildly elevated creatinine value of 144 micromole per liter and normal blood urea. But his urine fluid report revealed a pH value of 7.35 with a pus cells count of 30 to 40 with 2 to 3 red blood cells. And the urine culture and ABSD was able to isolate E. coli. So having more than 6 to 10 pus cells in a high power field of unspun voided urine is known as pyuria. So our patient is having pyuria. What are the differential diagnoses of having pyuria? It could be infectious or non-infectious. Under infectious, we can say differential diagnosis of urethritis, cystitis, prostatitis, pyelonephritis, perinephric abscess, and renal tuberculosis. Whereas under non-infectious pyuria, it could be uric acid or hypercalcemia-related nephropathy, inflammatory conditions like sarcoidosis or lupus, polycystic kidney disease, genitourinary malignancies, and even medications like NSAIDs. So we have done ultrasound scan abdomen and it revealed multiple bilateral nephrocalcinosis with mild hydroureter with acute pyelonephritic changes in the renal parenchyma. And also there were multiple calculi in both ureter. So our patient is having bilateral nephrocalcinosis complicated with infective pyuria. So what are the etiology behind this? Before that, we have to, I will briefly explain what is nephrocalcinosis and the pathophysiology behind this. So what is nephrocalcinosis? It's deposition of poorly soluble calcium salts like calcium oxalate or calcium phosphate, mostly in the kidney interstitium and to a lesser extent in the intratubular lumen, due to an imbalance between promoters and inhibitors of calcium salt precipitation. This line diagram will show how it grow in our body, the stone form in our kidney. So when there is excess insoluble salt compounds in the body, it will supersaturate. So this supersaturated solution of salts will be affected by the urine volume of the patient is producing and the urine pH value as well. From there, due to the physical promoters, chemical inhibitors, and the predisposing factors, lead to precipitation and the meatus formation further leads to growth of a stone. So in my next 2 slides, I will elaborate much on the chemical promoters and the chemical inhibitors and how they can give rise to formation of a stone in the body. So what about hypercalcemia? It's a physical promoter. Like in conditions of hyperparathyroidism, vitamin D intoxication, sarcoidosis, milk alkali syndrome, these patients have high calcium level. So due to that increased filtered calcium load, exceeds the tubular reabsorption of their body. So this will promote calcium to precipitate with phosphate or oxalate in the renal interstitium. Whereas wells of the kidney, like in conditions like with calcium and deposits calcium oxalate in renal tissue. In the hyperphosphatemic conditions, like in chronic kidney disease, these high phosphate levels will combine with calcium to form calcium phosphate crystals and they will deposit. What about the citrate level? It's as I shown in my previous slide, it's a chemical inhibitor. So in hypocitraturia, which usually found in chronic diarrhea conditions, this citrate usually inhibits the stone formation by binding calcium. So in the absence of citrate, this free calcium promotes the precipitation. And even in increased urinary pH conditions, like in renal tubular acidosis, this will favor calcium phosphate precipitation. So To exclude these chemical promoters and chemical inhibitors, we have further investigated these patients by doing serum and urine investigation. So his total calcium level was found to have very high, 12 milligram per deciliter. Phosphate was low, 0.7 millimole per liter. Ionized calcium also low, high, 1.84 millimole per liter. And his magnesium and uric acid levels were normal. And he was found to have very high PTH value of 54.33 nanomole per liter and low vitamin D level of 38.6 nanomole per liter and high ALP level of 304 units per liter. And his urine studies reveal there is hypercalciuria. He's having calcium hypercalciuria value of 14.83 millimole per liter for 24 hours. But his other excretion studies like creatinine, oxalate, and citric acid, they were not exceeded the upper limit. And also, we couldn't perform the urine stone analysis due to unavailability of the facility at that time at his hospital. So what are the remarkable findings in this patient up to now? He's having bilateral nephrocalcinosis with infective pyorrhea and found to have very high serum calcium, high serum PTH, high ALP with high urine calcium. So what are the differential diagnoses of having bilateral nephrocalcinosis with serum calcium level? This diagram will show if a patient found to have nephrocalcinosis with hypercalciuria, we can divide this patient into three categories according to their serum calcium level. So our patient comes under this high serum calcium category. So further, we can divide those category of patients into two according to their PTH value. So high PTH value and low PTH value. High PTH value patients, we can say these patients are having primary hyperparathyroidism. Low PTH, if the patient is having low PTH value, it could be other causes of hypercalcemia. So our patient, according to this diagram, you can see our patient fall into this category, like he's having nephrocalcinosis with hypercalciuria and high serum calcium with high PTH. So he will fall into this primary hyperparathyroidism. So what we did next? We did further imaging studies. We did ultrasound scan neck. It showed left-sided parathyroid adenoma with normal thyroid gland. And the CECT neck also confirmed that diagnosis. Further, we did technetium-99 system scan and it showed focal abnormal retention in the region below lower pole of the left lobe of the thyroid gland. These are the images. Then what's next? We have done, actually patient had undergone bilateral parathyroid exploration with excision of left-sided ectopic parathyroid adenoma. Following the excision, these are his post-operative findings. On day one, patient was quite okay. The symptoms were uneventful and there were no signs of Chostek's and Trousseau's signs and biochemical is stable. But on day 4, he was complaining of having epigastric pain and he was found to have mild fever. On examination, there was abdominal tenderness and the Chostek's and the Trousseau's signs were negative. So we ordered the blood test and it revealed he's having high calcium level, value of 12.2 milligram per deciliter, and amylase level value of 1,897 units per liter. And the other biochemical investigations are normal. Then we further, we thought, are we dealing with pancreatitis like episode as he's having high amylase level. So we did ultrasound scan abdomen and it revealed he's having acute pancreatitis at the moment. So he was given ICU care and vigorous intravenous fluid management under IV antibiotic coverage had been given and pain management was done. And further, he was he was planned to screen for Meniere's syndrome. And following the discharge, he was referred to JJ stenting for his nephrocalcinosis. So, what are the common biochemical complications following a parathyroidectomy? Usually 13 to 30% present with hypocalcemia, numbness, tingling sensation, muscle spasms, hungry-bone disease-like symptoms. But rarely these patients can develop hypercalcemia like in our patient. So what's the prevalence of having this scenario? Usually, the decrease of PTH by 50% or more from levels prior to surgery after excision predicts a successful parathyroidectomy. and the serum calcium is expected to return to normal within 24 to 72 hours after the surgery. But approximately 10% of patients have transient persistent postoperative hypercalcemia, which is more common in patients with higher preoperative serum calcium and PTH level, like in our patient. And acute pancreatitis commonly occur with hyperparathyroidism, but this can arise following parathyroidectomy as well. But how this is happening? Pancreatitis was significantly common when thyroidectomy was performed at the time of parathyroidectomy, secondary to a blunted T-cell response of calcitonin secretion to the induced hypercalcemia. And this hypercalcemia can cause ductal inflammation in the pancreas and ultimately pancreatitis. So the take-home message, nephrocalcinosis complicated by infectious pyuria may result from hypercalcemia secondary to hyperparathyroidism. Acute pancreatitis commonly occurs with hyperparathyroidism but can arise following parathyroidectomy as well. Careful attention should be paid to postoperative abdominal symptoms, for they may indicate pancreatitis. Doing postoperative day 1 serum amylase level is cost effective by minimizing hospital stay by detecting complications like pancreatitis at their earliest. These are my references, and thank you.